Everyone, and welcome. If you're a medical student, you definitely know that feeling, that moment of dread when a chest x-ray gets slapped in front of you during an OSCE. It can honestly feel like you're searching for a needle in a haystack. But you know what? It doesn't have to be that way. In this explainer, we're going to build a completely rock-solid, systematic approach that will let you tackle any chest x-ray with total confidence, especially when the pressure is on. Yeah, does this look familiar? That blank stare, the clock ticking down, and you're just wondering, where on earth do I even begin? Trust me, we have all been there. It feels overwhelming because there's just so much going on, and that fear of missing something absolutely critical is very, very real.
But here's the secret, okay? You don't need to be some kind of radiology wizard. You just need a system, a reliable, repeatable method that makes sure you check everything every single time. And that is how you go from feeling completely lost to being in total control of the situation.
So, here's our game plan. We'll start with the essential checks you have to do before you even look at the lungs. Then we'll assess the film's quality using the awesome RIPE mnemonic. After that, we'll dive into the core ABCD interpretation method, see how that helps us spot common problems, and finally, wrap up by learning how to present our findings like a pro.
Okay, first things first. Before you even think about looking for pathology, you have to get the basics right. Now, this step is super simple, but skipping it is one of the most common mistakes people make in an exam.
First, always confirm you have the right patient, the right film, and the right time. So, state the patient's name and age. Check the date and time of the film. Is this from today, or is it from last week? That's a huge difference. And make a note of the projection. Is it a PA or an AP view? Answering these simple questions right at the start can prevent you from making a huge mistake down the line.
All right, details confirmed. Now we have to assess the image itself. Why? Because a poor quality x-ray can literally create pathologies that aren't there, or, even worse, hide ones that are. And to do this systematically, we're going to use a fantastic mnemonic, RIPE.
This RIPE mnemonic is your go-to quality control checklist. So let's quickly break down what each of these letters means and why they're so important for getting an accurate read.
First up, R is for rotation. You want to look at the medial ends of the clavicles. You know, those little bony knobs right at the front? They should be the exact same distance from the spinous processes of the spine. If they're not, it means the patient was rotated when the image was taken, and that can make the heart look artificially bigger or smaller. It can even make one lung look wider than the other, which could trick you into thinking there's a pathology.
Next, I is for inspiration. In other words, did the patient take a deep enough breath? The way to check this is to count the ribs you can see above the diaphragm. You're looking for at least 6 anterior ribs, which are kind of faint and point down, or 10 of the more obvious posterior ribs. If you see fewer than that, the lungs are going to look all squashed up at the bottom, and that can easily be mistaken for pathology.
Okay, P for projection. Now this one is a huge deal, especially for exams. A standard, good quality chest x-ray is a PA view, or posterior anterior, but for really sick patients who can't stand up, we often get an AP, or anterior posterior view. And here's the key difference, magnification. On an AP film, because the x-ray beam hits the heart first before the film, the heart's shadow gets magnified. It looks bigger than it really is. This is a classic OSCE trap, so always check the projection.
And finally, we have E for exposure. Is a film too bright or too dark? A really quick way to check this is to look behind the heart. You should just be able to make out the outlines of the vertebral bodies. If that area is totally white, the film is underexposed. If it's pitch black and the lung markings look really harsh, it's overexposed.
Okay, so our film is ripe. We've confirmed all the patient details. Now we get to the core of the interpretation, the systematic ABCDE method. This is the framework that is going to guide you through the anatomy, in the same order every single time.
This right here is your new best friend. Airway, breathing circulation, diaphragm, and everything else. Seriously, think of it like a guided tour of the chest. We start right in the middle with the airway, and we systematically work our way out. Following this exact order builds a mental habit that stops you from jumping to conclusions and missing crucial findings. So we start with A for airway. Find the trachea. It's that dark column of air running right down the middle of the neck. Is it central, or is it being pushed or pulled to one side? Because if it is, that is a major red flag. If it's pulled towards a problem area, you should be thinking about something like a lung collapse. If it's being pushed away from a problem, you might be looking at something life-threatening, like a tension pneumothorax or a massive pleural effusion.
B is for breathing, and this is where we assess the lung fields themselves. Systematically compare the right and left lungs, zone by zone, upper, middle, lower. You're basically hunting for specific patterns. For instance, a pneumothorax, or a collapsed lung, will show a really sharp pleural line with absolutely no lung markings beyond it. A pleural effusion, which is fluid in the chest, will blunt those sharp costophrenic angles right at the bottom of the lungs. Just take a second to look at these other key signs for things like collapse and heart failure. Recognizing these patterns is everything.
Next up is C for circulation, and we start with the size of the heart. The key rule to remember here is the cardiothoracic ratio. On a good PA film, the widest part of the heart should be less than 50%, or less than half, of the total width of the chest. If it's bigger than that, that's a sign of cardiomegaly, or an enlarged heart.
C also includes looking at the mediastinum. That's the central part of the chest containing the heart and great vessels. Does it look unusually wide? This is a really critical finding that could point to something as serious as an aortic dissection. Also, you want to find the aortic knuckle. That's the shadow where the aorta arches over. Is it unusually prominent? Because that could be a sign of long-standing hypertension or even an aneurysm.
All right, on to D for diaphragm. The right side is normally a little bit higher than the left because the liver sits right underneath it. What you want to do is check the shape. Are the domes nice and curved, or are they flattened out? Because flattening is a classic sign of COPD. And critically, you need to look for a tiny sliver of black air under the diaphragm. That is free gas, and it means there's a perforation in the bowel, which is a surgical emergency.
And finally, we have E for everything else. This is your safety net. It's the step that makes sure you haven't missed anything. You're going to deliberately scan the bones, the ribs, the clavicles, the vertebrae, looking for any fractures. Check the soft tissues for any swelling or air, and don't forget to look for things like breast shadows, which can sometimes look like pathology in the lower zones. And of course, identify any lines, tubes, or pacemakers, and make sure they're in the right position.
So there we have it. We've got our system down, but the real power of the ABCD method isn't just about checking off boxes. It's about using what you find to recognize those classic illness patterns.
For example, let's say you're using your system and you find a localized white patch, an opacity, in the right lower zone during your B for breathing check. Your brain should immediately think pneumonia. Or maybe during your D for diaphragm check, you notice that they are super flat and the lungs in general look really big and hyperinflated. Well, that pattern just screams COPD, you see? The system helps you find the individual signs, and then your clinical knowledge connects them to the diagnosis.
Finding the pathology is only half the battle, especially in an exam. You have to be able to communicate what you've found clearly, concisely, and professionally. This is where you bring it all home and really impress your examiner.
A really professional report sounds something like this. This is an adequately inspired, well-exposed PA chest X-ray. The trachea is central and the mediastinum is not widened. The lungs show a right lower zone consolidation with visible air bronchograms. The heart size is normal. The diaphragms appear normal, and the costophrenic angles are sharp. Divisible bones and soft tissues are unremarkable. Overall, these findings are consistent with a right lower lobe pneumonia. See how that flows? It follows our entire system, quality, ABCDE, and a final conclusion. That is exactly how you want to present.
So, there you have it, a complete step-by-step system for interpreting any chest X-ray that gets thrown your way. From here, it's all about practice. The more you use this system, the faster and more intuitive it's going to become. So the only question left is, are you ready to go out there and tackle that next film?